good evening, everyone, and thank you so much for joining us to Let's Talk About Prostates, the conversation that can save a life. Before we start this webinar, I just want to say that this is more than a webinar. It's actually a movement where we try to break the silence around prostate cancer because the numbers are really alarming. Every 3 minutes, a man is diagnosed, and every 30 minutes, a man dies. However, do you guys know that when prostate cancer is actually caught early, 95% of them are treatable? So tonight's conversation is because this matters, because we all believe that knowledge that we gain from here could save someone's life, maybe someone you know, someone that you really love, or even someone like yourself that is actually here today carrying this disease but not knowing really what to do. I love statistics. I just want to give a little bit of statistics. In 2025, prostate cancer is actually projected to be the second most common cancer in the United States and is set to affect about 313,000 cases every year. There are new cases of 331,000. That is an alarming number. And globally, it's said to be the second most common cancer in men and the fifth leading cause of cancer deaths. And at the moment, about 1.46 million cases are seen globally. And it is projected that by 2040, the burden of this disease will double to 2.5 million. And therefore, the number of deaths will be 700,000 deaths. Because obviously the population is growing, people are living longer, and then it's most likely that people could see the contract this disease. But what we need to do is try and see how we can actually make sure that those numbers don't lead to deaths because this is actually a manageable pathology. Now, before I continue, I want to tell you guys a personal story. The reason why Animal Health actually exists today is that 14 years ago, I met a brilliant urologist called Roger Kirby. And the reason why I walked into Roger Kirby's clinic was because I had a relative that was dear to me who, during a routine test, he had no symptoms, no urinary symptoms, never been unwell, fit and well, does everything, plays golf, lived his normal life. He had a marginally raised PSA of 7.4. 2 days later, we're told he had prostate cancer. The way he actually treated my relative meant that he gave him a lot of dignity and respect, and he found this prostate cancer early, and therefore, 14 years later, he is still cancer free. Therefore, like his story, I think everyone else in this room who has been affected by this can also have this type of story to tell in a few years to come. Now, I want to say because the other thing about prostate cancer that is very alarming is that it's much more common in Black people, especially people of African ancestry, and most of them will get prostate cancer early, and normally it's an aggressive pathology when it happens. But what we need to realize from this conversation is that in this is not the time to be silent. We cannot afford to wait. What we need to know is that we need to tackle this global pandemic and actually be able to get people the help that they need. So tonight, Animal Health is working together with Circle Group, which is one of the UK's largest independent private hospital, to bring this knowledge to your doorstep. We're really privileged to have consultants who have years of experience, who have actually treated the upper echelon of the society and have seen loads of these cases and know what to do to help patients get better. First of all, joining us today is Mr. Paul Cleveland. He's a consultant urologist and a robotic surgeon who practices at Circle Group at Alexandra Hospital and the Circle Cheshire Clinic. His expertise covers prostate cancer, bladder cancer, and testicular cancer, but his special area of interest is actually robotic prostatectomy techniques that not only improve the outcome of men with prostate cancer, but actually makes their recovery a lot more tolerable. He's also deeply committed to diagnostic, treatment innovation, patient education, which is what we're doing tonight, as well as training the next generation of doctors and surgeons in urological care. Thanks, Paul, for joining us today.
Thank you very much for having me. Pleasure to be here.
Thank you so much, Paul. So we're supposed to have two other consultants join us, but as everything in medicine, they're currently stuck in hospital. We hope they will join us while we start this conversation. But we want to try and get this conversation started on time. So I want to do a few ground rules and I'll actually also introduce myself. My name is Dr. Chichi Menakaya. I'm also a surgeon, but I do a different type of surgery. I do hip and knee surgery. With Paul, I work with a lot of robots, but a different type of robots also because I'm a hip and knee robotic surgeon. And as I said to you guys, prostate cancer is very close to my heart because I've had to live through it with a relative I loved so much, who today, because of early detection, is still living his life, playing golf, even in old age, and just having fun. So, a few ground rules. We're going to have a few sets of questions that we'll speak to Paul about. And then I expect everyone today to have a huge opportunity to speak to Paul. It's not every day you get Paul to come out of his busy timetable to be here to speak to us about prostate cancer. And then hopefully within 30 minutes, we should be able to address your questions. Please send the questions mostly to either myself or anyone else that you see that is called Anomo Health, and we'll try and address your questions. So thank you so much, Paul, and let's kick off. Thanks, Paul. So, Paul, I know I talked a lot about what you do in terms of you being a robotic surgeon and doing urology. I just thought it was always nice to start out from hearing from yourself because I read all those things about you and I'm like, maybe a lot of people don't understand what a urologist is, right? But I understand it. But I just want to know what does it feel like? What does your day-to-day look like with your prostate cancer patients?
Yeah, so I'm a consultant urologist. So my specialty is the surgical and medical management of patients who have issues with any part of the urinary and genital tract. So that includes men and women. So looking after the kidneys, bladder, prostate, and the male genitalia. So my subspecialty interest is in prostate disease, including cancer and benign conditions. But I practice in all of the other general urological conditions. So the large part of my practice is seeing new patients who are being either suspected or investigated for prostate cancer, men who've got difficulties with urinary symptoms, and then I undertake the consultations, the diagnostic procedures, counseling, talking about risks, risk stratification. And then once the diagnosis has been made, then I take part in the treatment of prostate cancer. There's several options in how you can treat prostate cancer, and my main focus is, and as you said, in robotic surgery for that. So my day-to-day, includes a mixture of clinics, doing ward rounds in the hospital, on calls, operating and surgery, and taking part in the multidisciplinary team meetings where we have a holistic approach to managing patients with new cancers. Lots of different doctors from different specialties get together and we have careful discussions about how to manage these patients.
Okay. Thank you so much, Paul. I think like it's so nice to hear like when you talk about multidisciplinary team, I think that's really important because a lot of people that live in developed countries or developing countries, right? People don't realize that most doctors don't work in isolation anymore. And we have a team of people that we work with. And that's why conversations like this are great because we carry our patients along, right? To be able to see how do we help them. And I think my first question is this. A lot of people seem to not understand what the prostate gland is, right? Because you hear a lot of people say they said I have prostate, and I'm like, yeah, the prostate is normal, is in you when you're born, right? And they use that word to describe the condition that they're going through. So I'm just wondering whether you could explain to us what the prostate gland is exactly, right? Before we dive into the pathologies that affect the prostate gland.
Sure. Yeah. So that's a very good and relevant question. So every male man is born with a prostate, as you said. It, in terms of his anatomical location, is placed between the bladder and the urethra, so the pipe where urine comes out. It is a gland, so its main purpose is to produce secretions or fluid, that it's involved in sexual function in men. So its main purpose is to produce the fluid that comes out when a man ejaculates, and that's to lubricate the semen to allow insemination and conception, to have children. It's also involved in your urinary tract, so your urinary control. It's involved in a very complex structure called the urinary sphincter, and so it allows men to be able to control their bladder. The sphincter closes when you want to keep the urine in, and then it opens when you want to pass urine. And so that's why, as prostate develops disease, these are the symptoms that men will encounter with time. So that's the basically the main role of the prostate and where it is.
Thank you so much. So I'm going to dive on to the next question. You talked briefly on the fact that the prostate gland is not just affected by cancer, but there are also some benign conditions. I think the one that I know quite clearly is the benign prostatic hypertrophy. So I think it'll be nice to like just explain what the difference is and what's like whether is there a symptom interchange or is just different pathologies normally.
Yeah, so as you said, so benign prostatic hypertrophy is where you get growth of the prostate tissues, but this is not related to cancerous change. So this will happen in most men as they grow older, and it's related to testosterone, which is a thing that drives growth in the prostate. So some men are at an increased risk of developing that compared to others. You already mentioned ethnicity, which is an important factor. But benign growth doesn't necessarily lead to problems. Now, there is a correlation between the size of your prostate and developing symptoms. So as your prostate grows, it starts to pinch or obstruct, cause a blockage in the outflow of urine from the bladder. This can then mean that the bladder is working harder to try and squeeze the urine out, and so in turn it will lead to urinary symptoms, so difficulty passing urine or going to the toilet very often. Now, if there is an issue there, you can then develop other conditions related to the prostate, such as inflammation or infection of the prostate, which is known as prostatitis, and urinary tract infections, as well as other symptoms like blood in your semen. And these are all related to growth or benign growth of the prostate. Now, if these symptoms become problematic, then there are things that we can do to try and relieve those symptoms. Now, that's different to prostate cancer, where you have abnormal growth of the prostate cells, which become very different to what they should look like. And so this then leads to growth that starts to invade or replace normal cells, normal tissue, and leads to damage. And eventually those cells can spread and cause further cancer spread and disease, and lead to the problems you've mentioned before, symptoms, and eventually lead to shortening someone's life expectancy.
Perfect. Thank you so much. I think, Paul, I'm going to take a minute to introduce Professor Imran, who has just joined us, right? And I think I'm just going to bring him on. So Professor Imran has just joined. Professor Imran is also a consultant urologist and robotic surgeon from Ross Hall Hospital, all the way in Glasgow. He's also known to be a high volume robotic surgeon like Paul, which is great. And also, he's known to be one of the pioneering members for research when it comes to prostate cancer, not just in Glasgow, but also part of the UK. And beyond this, like Paul, he loves to train the next generation of surgeons, because I think once you've done the great job, it's always good to hand over to someone else. Thank you so much, Imran, for joining us today.
Oh, no, it's a pleasure. Thanks for having me.
Thank you so much. So I think also that Dr. Abdullah Al-Halso is here now, if I can find him. So also joining us is a consultant clinical oncologist, also all the way from Glasgow. He's also known to have helped in the establishing of the advanced radiotherapy services at West Scotland, and also the image-guided radiotherapy for prostate cancer. He's also a co-founder of the Glasgow Oncology Clinic. So I think we have such a powerful panel today. So I think for people joining wherever you're joining from, this is your opportunity to actually put questions in the chat box and actually ask questions, because we never get this lucky to have this great people talking about prostate cancer at a time like this, when there's like a pandemic for prostate cancer, where we need to try and do something about prostate cancer. So I'm going to continue with the questions, and I'm going to go back to, okay, Prof, sorry, you just came in, Imran. So I'm going to have to dive to you, because we need to hear your voice, because Paul has been holding the fort for everyone since, right? So I guess my question is, what are the risk factors for men that they should be aware of for developing prostate cancer?
Yeah, I suppose this call is quite timely. One of the big risk factors is being of Afro-Caribbean descent. And we know that increases the risk of developing prostate cancer. We know Afro-Caribbean men develop it younger, and usually in a more kind of aggressive form. The other big risk factor is family history. So we know about 10 to 20% of men will have a positive family history, and the kind of common mutations we look for, the kind of BRCA mutations, the checkpoint, the kind of DNA damage repair genes that are mutated. And what makes us think, if someone got positive family history, is if they have 2 or 3 generations that have developed prostate cancer at a young age, particularly in their 40s or 50s, as well as a strong history of either breast or ovarian cancer. They're the main risks. I think there's a lot of stuff in the media about things like diet, red meat, all these kind of things. But the reality is none of them have really kind of borne out. And the biggest risk factors are ethnicity and having a positive family history. Obviously, being a man and older is the risk factor we can't get away from as well.
I think that's sad to say being a man, just being a man is just a risk factor and getting older. So, Paul, I was going to come back to you to say, what are the early warning signs that people ignore? Like for my relative, he had no symptoms, right? He just does a routine test. He never had any symptoms at all. But are there things people should be looking out for? Because I know Imran alluded to getting older being a risk factor.
Yeah, that's correct. And I think the reality is that a lot of men won't have any symptoms early on, and they won't present with symptoms. It will be that they've had a routine blood test for PSA. But in terms of urinary symptoms, that's the main thing that men will get early on. So there is an association between prostate cancer and developing urinary symptoms, as well as benign growth, as we described previously. So in terms of the type of symptoms that a man may get, well, they will get what we call voiding symptoms, which is difficulty initiating the stream of urine, taking a while for that urine to finish. So also a poor flow, an intermittent flow where you get stopping and starting of the stream, and having this feeling that you haven't quite emptied your bladder, and so you're having to return to the toilet to pass urine again. Men will also find that they're going to pass urine to the toilet more frequently or urgently during the day. And one of the classical symptoms is getting up at night. So if a man is getting up multiple times at night to pass urine, we're talking 3 or 4 times at night, then that's not normal. It is normal as you get older to start to get up at night, maybe once or twice, but if you're going more than that, then that is an issue. And that can ultimately lead to more problems in terms of not being able to completely empty your bladder. You can sometimes get blood in the urine and blood in the semen, but this is less common. So early symptoms tend to be urinary symptoms. Those are the things to look out for.
Thank you so much. I guess that brings me all to Imran. Are you there? Okay, let me go back to forward then. So I was just thinking, I think the next thing is like PSA, PSA, PSA. Everyone talks about PSA test, which can be very confusing, right? What does PSA really mean? Is that the only test that we use for diagnosing or monitoring prostate cancer? And also, are there any tests that might be elevated? I know that Imran alluded to risk factors like BRCA gene being a risk factor, but I'm just wondering what are the tests, what the PSA tests, and just there's a bit of confusion because everyone talks about the PSA all the time.
Yeah, so the PSA, well, it stands for prostate-specific antigen, and it's a glycoprotein that's produced by the prostate. There is an association with it, the levels being higher on the blood test results if you have prostate cancer. Now, the difficulty with PSA is that it's not 100% accurate, and so it's not got the best sensitivity or specificity. And so that means that you can have a negative PSA blood test, yet there's about a 15% chance that you could still have prostate cancer, even with a normal negative PSA. Likewise, if the PSA is elevated, actually about 75% of men don't have prostate cancer who have an elevated PSA. So it by itself is not the way to diagnose prostate cancer, but it's the first thing that will alert us that you need further investigations. Now, PSA is the test that's been around the longest, but there are newer methods to try and improve the accuracy of the test. That includes other varying types of PSA assays that you can find in the blood, such as free to total PSA ratios. We also look at the PSA kinetics, so what the change is, how rapidly it's going up or doubling. And in addition to that, there are newer tests that you can get, the kind of sort of risk stratification tests, things like the Prostate Health Index, which is a test where you combine different isoforms, free and total PSA, to get a risk score of the chances of you harboring prostate cancer. In a similar way, there's a Stockholm 3 test, which combines, again, the PSA genetic markers, biomarkers, and creates a risk score of predicting what the chances are of you developing prostate cancer. Now, again, these tools by themselves aren't the only way to diagnose it, but they're things that can quantify the risk for a patient. There's a urine test called the PCA3 Progensa, which again looks at combining mRNA biomarkers in the urine after a prostate massage to assess the risk. And then one of the newer tests that I've dealt with recently, which is very exciting actually, is called the Prostate Specific Epigenetic Test, or PSC blood test, which they have just concluded trials, and it looks like it has a very good accuracy at detecting prostate cancer. So it's got 97% specificity, and it aims to reduce unnecessary tests. So it's something that I've started looking at and using to try and quantify risk for patients. So these are the tests that you can use in addition to the PSA blood test. Now, if your PSA is elevated, then the way to investigate whether you've got prostate cancer now is to get a scan. So an MRI scan, magnetic resonance scan imaging, where you have different phases, and that gives us a score as to what the likelihood is if you're having prostate cancer. And subsequently, if it's positive, you then have to undergo a biopsy of the prostate to get histological tissue confirmation.
Thank you so much. Professor Imran, are you there? Yes, thank you. So I guess my question to you is, I know Paul has talked about all the investigations that we do. So I'm just wondering that what are the treatment modalities that involve surgery, and how do you decide that the patient needs robotic surgery?
Yeah, so usually the kind of pathways quite straightforward. That most patients will have a PSA that's come back as elevated, or the patient's had an examination by a doctor and the prostate feels abnormal, and at that stage you'll have an MRI which is showing an abnormality in the prostate that's been biopsied that's confirmed cancer. And just depending on the MRI and the staging from the biopsy, that may trigger a few more scans in the form of a CT bone scan or a PSMA. And the biggest factor to kind of decide whether someone's fit for surgery is essentially is a disease localized to the pelvis. So is it either just in the prostate or just coming out? If there's lymph nodes, are the lymph nodes just in the pelvis? And make sure there's no spread anywhere else. We need to make sure that the patient is fit and that they will kind of at least survive 10 years from the surgery, irrespective of other health problems, and that the patient's informed and motivated to have an operation, understand that the risk factors and what could potentially go wrong. And touching most of the time it doesn't, but I think for me, I always paint quite a bleak picture from surgery, and usually it's not that bad. But as if someone goes in informed with their eyes open, I think that makes a big difference to how they deal with the kind of after effects of surgery.
Thank you so much. Dr. Alhasu, are you back?
Yeah, I am in.
Can't see you yet. Okay. Your video seems to be off. Can you see us?
Can you hear me?
Yeah, we can hear you, but we can't see. Yes, thank you. So I just wanted to touch a bit about what we've talked about. Obviously, robotic surgery is an option, but also, how do we know how aggressive this disease is and whether it has spread? And is this important for the treatment modalities? Like, I think Imran talked about it a little bit about obviously doing the scans and seeing whether it's spread. And if we can't do surgery, what are the other options? I think that's what most people want to know, especially since Africans normally will get it early and they get a more aggressive disease.
Right. Okay. So the first, I suppose, part of your question is about how aggressive is the disease. And there are a number of factors that we obviously look at when we evaluate the aggressiveness or the type and nature and the biology of this cancer. One is from obviously the PSA itself. We spoke about that earlier. So how high it is. So obviously the higher the risk, and the more likely to be associated with a recurrence. There are things we look at in terms of the biopsy, the tissue analysis. So you have a grade of the cancer. So you could have a low grade, intermediate, and a high grade, and that influences significantly the management plan. And then you have the extent of the disease. So this is whether it is just confined in the gland and it's a big volume, small volume, whether it's going through the capsule of the prostate or not, involving the nodes, the lymph nodes or not, or going into other organs. Now, prostate cancer commonly go to the lymph nodes as well as bones, and that the assessment of the extent of the disease will reflect on how likely and how aggressive is the cancer, and then that influence the management plan. In terms of staging, And how do we know the extent of disease? I think it's been touched on by colleagues earlier. A clinical assessment, number one, and number two is the imaging, which usually include an MRI scan of the prostate, which is the gold standard for local staging. And in those who have a higher risk features, we will be keen on assessing their sort of systemic disease or the distant disease, so bone scan and a CT scan of their chest, abdomen, and pelvis. And there are obviously the new imaging modalities. Again, I touched on earlier, there is the PSMA scan as well that has been integrated and is becoming more and more part of standard of care. So these are the way how we assess the aggressiveness of the cancer and then decide on the modality of treatment, and also how we assess the extent of the disease.
Okay, thank you so much. I know you touched about, obviously, you talked about robotics, and you talked about how aggressive it is. I know that radiotherapy plays a very major role, right? And it's sometimes also considered as primary treatment. I say so because in the situation I shared, he was meant to have robotic surgery, but then because it was quite close to the urethra, Professor Kirby opted for him to then have radiotherapy and then have hormonal treatment, right? And I guess that's down your Ali, in terms of what are the different types of robotic radiotherapy that are available and how curative it is. Because I think as family members, right, when you're in this clinic and they tell you they can't have surgery, you give up hope. You're like, oh my God, if they don't take it out,
Yeah.
then how it's going to be cured, right? And I think for me, even as a surgeon, I went through that process when I was told last minute, 2 days to the surgery, oh no, we can't do surgery anymore because we could give him incontinence. Let's do radiotherapy. And I think people want to know that, is radiotherapy curative, or and what are the types available?
Okay, a very good point. So essentially, radiotherapy, yes, is considered a curative treatment. And in general, the role or the efficacy of surgery, as in radical prostatectomy, is considered to be equivalent to that of radiotherapy. But it is important that we select the treatment modality based on patient general health, patient's characteristics, and their disease characteristics as well. Okay, so for some patients, surgery will be the best option. For others, radiotherapy is the best. And for other patients, sometimes we have to consider the combination, in fact. Okay, or indeed, it could be an active surveillance, so neither will need to be considered. Okay, so it's all these factors that play a role in deciding which one. But they are, if radiotherapy is an option, then it is considered a curative option. The types of radiotherapy is the second part of your question. There are several types of radiotherapy. Now, we are talking here about radical radiotherapy options. So one is called external beam irradiation to the prostate, which is probably the commonest type of radiotherapy to prostate. And within that, you have a number of subtypes. So there is, we call it an IMRT, intensity modulated radiotherapy. And you have another version, another terminology. We call it SABR, which stands for stereotactic axial body radiotherapy, which is more intense and more focused, but as effective though. Okay, and there is an option of radiotherapy from within, which what we call it the brachytherapy as well. But again, within all these options, this spectrum of options, we have to be careful in selecting the patients. So some patients may be suitable for brachy, others may be suitable for SABR, and so on. But in general, they are considered to be all effective as long and, well, equally effective as long as you use it in the right patient that is specifically designed for that treatment.
Thank you so much. Thank you so much. I think that comes and brings it back to Paul. We talked about the fact that there is side effects for robotic surgery. I think a lot of men really worry about things like sexual dysfunction, urinary incontinence. Like I said to you, my relative was supposed to have robotic surgery, and the doctor said because it's so close to the urethra, I could leave him incontinent, right? Does robotic surgery really minimize this risk? And if they do, is there like a recovery if, like, post-op, they had a bit of incontinence or sexual dysfunction?
Yeah, that's right. So I think, we can't get away from the fact that robotic surgery has revolutionized the surgical treatment of prostate cancer. In my practice, I use the Da Vinci Xi robot, which is probably the most commonly used robot. Now, the benefits are that it's more precise, and so it's also minimally invasive, so the wounds are smaller. So the real benefit is in terms of recovery and the length of stay in hospital. So that's dramatically been reduced. Most of my patients go home after the day they've had their operation. It also minimizes complications during the operation, mainly things like blood loss, which you can get with any type of surgery. As a surgeon, I can definitely attest to the fact that it is definitely a better and more efficient, accurate way of treating the disease. Some of the benefits in terms of functional outcomes is that because it's more intricate and you're able to see more closely, you're able to preserve the structures that are involved in both continence, so the structures around the sphincter, as well as the nerves. So the nerves that allow you to get sexual function or erections are on the prostate next to it. And with robotic surgery, due to the precise accuracy of the instruments and the controls, we are able to preserve those nerves to maximize recovery. Now, I perform a technique called Retsia-sparing prostatectomy, which preserves even more of those structures around the sphincter. And so what we found with that, and the evidence shows that there is a quicker return to continence with that technique. So a lot of my patients will regain their continence within weeks after having the surgery. There is still that long-term risk of incontinence, and that varies across the country. But overall, most men tend to recover to an acceptable level. But there is, as you said, still that risk of having long-term permanent incontinence. And there are certain criteria that we look at when we select patients for surgery.
Thank you so much. Imran, do you want to add to that from your own experience also with sexual dysfunction and urinary incontinence? I think is a big topic for a lot of men, right? And
Yeah. No, definitely. So I think urinary incontinence is much better than it used to be after surgery. And I quote the patients, about 5 to 10% of men after surgery will have a degree of incontinence long term. The other 90% will essentially be pad free or using a security pad. But 1 in 10, 1 in 20 men will continue to use pads, and they'll have stress incontinence when they're coughing, sneezing, lifting weights. Most men are just happy to manage it with pads. A small proportion want it fixed. So then at that stage, we decide whether to put an artificial sphincter in, and we don't usually do that before a year because we know the recovery for continence. Even though most men regain their continence within days to weeks, some can take up to a year. There's no getting away from erectile dysfunction. I tell all men they will have erectile dysfunction after the operation. And I tell men if erections are the most important thing in your life, don't have an operation. I'm upfront with them that way. So even if you do the best nerve sparing in the world, men still have erectile dysfunction, and it can take time for it to come back. So if you do an aggressive nerve spare, that means spare the nerves from the capsule of the prostate because the cancer isn't there. About 60% of men will eventually regain their erections over the next 12 to 24 months. But often those men that do get the erections back still need to take medications to help them with that. So it's very rare for men to get spontaneous erections without a PDE5 inhibitor such as Viagra. But it's not that bleak in that men that aren't able to get erections after the operation. There's a whole kind of plethora of agents now available to help the kind of penile rehab, whether it be penile pumps, intracavernosal injections, all the way up to kind of the penile implants. But I'm upfront that the erectile function is the big issue after this type of surgery. And although we're better at sparing the nerves, most men will suffer erectile dysfunction after surgery.
Okay. Thank you so much. Dr. Abdullah, I was going to ask you about radiotherapy, if you're there. Radiotherapy,
Yeah, I am.
Any effect on sexual dysfunction and urinary incontinence? Because I think a lot of people on this call would like to know, because I think that's one of the questions that we got.
Yeah. Yeah. Okay. So a couple of points to say. Number one is, sorry, can you hear me? Yeah. Yeah. So first of all, it depends on obviously the type of radiotherapy and whether we are actually including hormone treatment with it or not. And if we are including hormone treatment, whether we are giving it as a short-term hormones or a long-term hormones. So unfortunately, hormone therapy will be associated with significant impact on sexual function for obvious reasons. And obviously for the duration and likely beyond that, because there will be so if somebody has been on hormone therapy for example, 6 months, it will take them easily another 6 months to recover their hormonal function. And so it can become more complicated. And I think almost all patients will have erectile dysfunction and sexual dysfunction. But if we're talking about radiotherapy alone, okay, then the external beam radiotherapy is generally associated with about 50% risk of erectile dysfunction over 5 years. So it's practically 50-50 chance having radiotherapy. You may have erectile dysfunction over 5 years, or you may not, okay? And it's difficult. There is no sort of way to predict who will not. But those who have comorbidities like diabetics, heart problems, and other comorbidity obviously make things worse. Brachytherapy is generally considered to be less toxic from the sexual point of view, and typically the trials and data have sort of the figure quoted for erectile dysfunction with brachytherapy is about 30%. So it's still high, but is obviously less than the 50% quoted for the external beam. So these are the figures. And in general, I think it's important, obviously, we highlight all these issues to the patients, and we try and optimize their quality of life and their pelvic function before going ahead with any treatment. But these are the figures that we will quote patients when we discuss these options with them.
Okay, thank you so much. You talked a bit about hormonal therapy, so I was just going to get you to cast a bit of light on it. I know some men have also complained about things like gynecomastia with the hormones, right? And other things apart from sexual dysfunction, which is like enlarged breasts for some of the men. I'm just wondering, how does hormone therapy work, and where is that also, is it ever like a primary treatment for curation, or how does that work in the whole picture?
Okay, so in general, hormone treatment is in the context of a radical treatment, or particularly radical radiotherapy, is an adjunct to it, is an additive, but not a curative on its own. Okay, so that's one. And when we use it, it does optimize and improve on the radiotherapy outcome quite significantly. That's why it has become an integral part of the overall management plan. And usually it is indicated, just to sort of put it in a simple way, for those who have intermediate risk prostate cancer, we usually consider them for a short course of hormone treatment, which is something in the region of about 4 to 6 months. And for those who have high risk, locally advanced, basically prostate cancer, in general, we consider them for treatment that goes on for between 2 to 3 years. Okay? Now, how does it work? Again, it depends on the type of hormone treatment we use, but let's say the conventional type of treatment, like a drug we typically use here in the UK, is the Prostate, which is an LHRH agonist, and basically it suppresses the production of testosterone, and therefore deprive cancer cells from testosterone that usually in normal circumstances feed the cancer and stimulate the cells to divide. So when we deprive the body from testosterone, the cells stop dividing or significantly reduce division. And that's how we can reduce the bulk of the cancer this way. But obviously, when you reduce testosterone, it is important hormone for various body functions. And therefore, obviously, one of the main effects is sexual function, but it will have an effect on the metabolic effects, cardiac effects, bone health as well, and mental function. So all these things are actually comes into it, and also gynecomastia, as you hinted at earlier. So whereas there are some other type of hormone treatment, typically the bicalutamide, which is an oral version, this one is more likely to be associated with gynecomastia, just because it works in a slightly different way. But in general, the effects of hormone therapy is systemic. So it's not obviously just gynecomastia, it is a multi-system effect.
Thank you so much. Thank you so much for sharing that with us. So I think that for people just joining us, we've got two brilliant robotic urologists talking to us about prostate cancer and an oncologist. And I think it's time we go to look at questions that the audience have, and then we're going to continue if we don't have any questions. So if you're joining and you have like some burning questions, we've been talking about things like what the prostate gland is, the fact that every man has a prostate gland, right? And then we've gone all the way to talk about what the options are, things like benign and cancerous that can affect the prostate gland. And then we've gone on to talk about the options all the way from just doing hormone therapy to what the risk factors and all the way to like having like prostatectomy via this to specialized people that do a lot of robotic work that is meant to make the outcomes of men a lot better. So I think the first question goes to you, Paul. It says, "Good evening. What is the best option for someone who has recently been diagnosed with prostate cancer based on the rising PSA, DRE, MRI, but now looking to travel to the UK for biopsy and treatment?" I guess he's saying, should he have his biopsy done locally, or should he just come and have the biopsy done and have the treatment at the same time?
That's a good question. So I guess it very much depends on what the facilities available are locally. So there are different ways of performing a prostate biopsy. Traditionally, it'd be performed through the transrectal route, but now we've moved away from that to go through the perineum because there's a far less risk of developing urinary tract infection and sepsis. And I mean, the accuracy probably is better as well. We also use a technique where you perform fusion biopsies. So that's where you use the images from an MRI scan and fuse them with the images from the ultrasound scan that you use to perform the biopsy. And it's thought, and some of the evidence shows that it does or can improve the accuracy of the biopsy. So we're targeting a specific growth or abnormality in the prostate, and by fusing those images, it should, in theory, give you a more accurate result when you get your biopsy. So if you're looking at the best available technique to do that, then that's probably the way to go. And then in terms of treatments, very much depends on what the diagnosis is and what treatment would be available.
I was just going to ask, like, if you were going to like, so the person sounds like they're very keen to come over to the UK, right? Would you prefer to do the biopsy yourself when they arrive, or should they have this done locally so the results are available for when they come to the UK?
Yeah, I mean, my personal preference would be to do the biopsy myself because then I know, exactly what I'm dealing with, and I know my own outcomes. It's difficult when they've had a biopsy elsewhere and a scan elsewhere. You'd have to review that in your multidisciplinary team meeting to ensure that it's a good quality biopsy.
Okay. I think it's good. Like, I know Paul mentioned multidisciplinary team meeting, but for people listening, what it means is that, like in the UK, like standard practice, we will discuss your case with other doctors from different specialties, like the oncologist, the urologist, and even the people that do the imaging to make sure we're doing the best thing for you. So I think we will drop an information for this person to send across the medical records so we can share with our consultants and then take it from there. So that's doable. And as he has advised, perhaps the biopsy is best done by himself or Professor Imran, because they're both urologists, to be able to, like, before we determine what the next thing is. And then obviously Dr. Abdullah can see whether is there a place of hormone, or is this just that the person goes ahead and has surgery. So I think the next question goes to Imran. So they've said, how often can the PSA test be done? I think a lot of people, once they've been diagnosed, do the test every single month.
No, so yeah, I think it starts to lose a bit of kind of clarity if you do it too often. So it really depends. So are you doing the test before you've got a diagnosis? Are you doing it in the lead up to a treatment? Are you doing it after treatment? But certainly I wouldn't recommend repeating the test less than 3 monthly. I'd say the minimum wait about 3 to 4 months, so we actually start to have an idea of the dynamics and how it's changing.
Okay. So there's no number to it because in the summary. It's not a
Yeah.
specific time. Okay, that's it. Okay, thank you so much. So I think my next question, there's a lot of noise somewhere. I'm not sure what that's happening. I think my next question goes to Dr. Abdullah. Can drinking water and other fluids so late at night be responsible for urination 3 or 4 times overnight? Or could this just be related to prostatic problems? Dr. Abdullah? Yeah.
Sorry, I couldn't hear you clearly. Can you repeat the question, please?
Can
Yeah.
drinking water and other fluids till late in the night be
Mhm.
responsible for urination 3 to 4 times overnight, or could this be related to prostatic problems?
Yeah, I mean, I think definitely it can be related to worsening their urinary symptoms, and quite often we actually advise patients to try and avoid drinking at night, particularly sort of coffee and tea. So yes, it can, and that could be just because of sort of they are drinking plenty of fluid. So therefore, if you drink more, you pee more. But also, obviously, there are local factors, whether they have sort of BPH or they have had treatments for their cancer, and for example, radiotherapy could have an effect as well, and potentially a long-term effect as well. So the short answer is yes, and quite often we do need to advise patients about their fluid intake, particularly in the evening. Plus, we generally, in my practice, and we work closely, myself and Professor Ahmed as well, we do refer to back to urology for further assessment and evaluation of their sort of bladder outflow studies and so on.
Thank you so much. Thank you so much. Imran, this comes to you also. Thank you for your presentation. Does the PSA test help in finding out benign growth in the prostate?
Yeah, so prostate cancer, as Paul was saying, is a kind of not just a marker for cancer, it's a marker of benign enlargement infection. And often, if you can use the prostate cancer, the PSA as a surrogate marker for prostate size. So, very old, rough rule of thumb is that for every kind of 1 point of PSA, you factor in 10 grams of prostate. Although it's a very rough rule, and but sometimes PSA itself can be used to kind of size the prostate. And one reason that men have high PSAs is because the prostate is very enlarged, which is why we always use PSA density as well when we're looking at the risk of someone having prostate cancer.
Okay, thank you so much. And then I'm coming to you, Paul. It says, thank you so much for all the expert speakers. I have learned a lot within a short period of time. Thanks all our speakers, and people appreciate what you do. My question this time is PSA of 6.35 nanogram per mils a danger sign?
So in terms of PSA, we often try to use age-specific reference ranges. So it very much depends on the age of the patient. It also depends on the lab reference where the PSA test has been done. Broadly speaking, we would normally say that a PSA above 4 is elevated, but we take the patient's age into consideration. So the older you are, we expect that your PSA should be slightly higher. So as a sort of rule of thumb, if you're over the age of 70, then a PSA of greater than 4.5 would be deemed to be abnormal. If you're, say, younger than that, between the age of 40 to 50, a PSA of greater than 2.5 would be something that we would be looking at being abnormal. Now, if you're over the age of 80, then we have to assess that based on how you are. But at that level of PSA, depending on the age, it probably is elevated.
Thank you so much, right? And just a follow-on question to Abdullah. It says, how true is it that infrequent sex or abstinence from sex over a long period of time with one spouse, of course, contributes to the development of prostate issues?
Okay, sorry. So, okay. So I think I didn't hear you very clearly, but I think you were
I think that's
talking about.
actually for the urologist, right? Maybe it's not for the
Sorry.
oncologist. So he says, how true is it that infrequent sex or abstinence from sex over a long period with one spouse will contribute to the development of prostatic issues?
Okay, my answer is I don't think it contributes, but I welcome my urology colleagues'
That's
comment on that.
the urology
Yeah.
consultants are the ones. This is down your alley. I'm happy for Paul or Imran, whoever wants to help us with this.
I mean, I'm happy to take that. So yeah, I think it is something that is frequently asked sometimes about what the correlation is. So no, we don't have any strong evidence at all really to link sexual activity or abstinence with prostate cancer. There is a school of thought that regular ejaculation can help with prostate health, but I don't think we can make a direct link between that and prostate cancer. Certainly, there's no link between having different, sexual partners or being with the same sexual partner, because it's not a sexually transmitted condition. I'm not sure what Imran's thoughts are on that, but I wouldn't think there is a link.
Yeah, no, I don't think there is a link. People get hung up about ejaculating a lot, ejaculating a not a lot. I don't think it makes much difference. I kind of usually reassure men that no, I don't think it's going to change anything.
Okay, thank you so much. So I think, Imran, this comes to you actually. I know there's a lot of advancement in research, right? What's going on, especially when people have advanced prostate cancer. And also there's been a lot of conversations on screening. What are your thoughts about screening men, like routine men, like we do breast cancer screening when people are a lot older, and we do like cervical cancer screening? Do you think there's a role? And what will that modality look like?
Yeah, we could spend days talking about screening. It's very kind of controversial, kind of hot topic. I think in the UK that we're about to embark on the Transform trial, which is a population-wide screening. My personal feeling is I think that's probably the wrong way to go. I think we need to be smarter at screening men who are at high risk, and that includes men with kind of family history, ethnicity, as well as identifying men who might not know at high risk to pick them up, because the worry with screening everyone, we'll start to pick up a lot of indolent prostate cancers that are low grade, giving men that kind of prostate cancer passport diagnosis. And that encourages people to have treatment surgery when they don't actually need it, when it would be best just watching it, because that cancer isn't going to cause them any harm. So I am a strong believer of screening, but I think it should be targeted screening of those at risk rather than screening everyone. And what was the other part of your question about the kind of advances in advanced prostate cancer? Yeah. So maybe Abdullah might be able to answer that better, but up until about 20 years ago, the only treatment that we had for advanced metastatic prostate cancer other than ADT was docetaxel. And in the last decade plus, we've seen a whole plethora of newer agents come, which has totally changed the field. But Abdullah's the one that's on the front line prescribing these treatments. So I'd welcome his thoughts about it.
Okay. Abdullah, I think we're back to you to give us the new things going on that we want to hear about.
Oh. Yeah. Okay, great. Well, certainly. I mean, I think when I first started in oncology and in prostate cancer management over 20 years ago, we were at the very basic level and using basically hormone treatments, as in sort of LHRH and orchidectomy. And then chemotherapy came in around 2004, 2005. And that sort of created a lot of excitement that we are able to do something else, a little bit different than hormone treatment, although it was of limited benefit, but it was a significant benefit. But over the last, maybe I could say last 10 years, there has been a revolution as far as prostate cancer, metastatic prostate cancer is concerned, and indeed even locally advanced. So there are, in addition to chemotherapy, now we have second-line chemotherapy, we have several very powerful, potent hormonal agents, particularly anti-androgens. And we have additional chemotherapy. We have additional radionuclide agents like lutetium, for example. And earlier than that, we had the radium. So there are a spectrum, really, of systemic treatment options that we can consider. And that spectrum is only actually expanding more and more. And again, just like what we discussed earlier about different types of radiotherapy, there are different types of systemic treatment, and you have to individualize and choose the treatment that is suitable for that specific patient. So it's difficult to generalize, and that is why we just have to assess the patient or the cases one by one. And consider the best option for that particular patient. So you could patient could have prostate cancer, but they will be treated differently. and in different sequence as well. And let's also keep in mind the BRCA status, which is the genetic sort of link of prostate cancer, have also a specific treatment modality that exists for these patients as well, widening the spectrum further. And I hope and expect that there will be further options coming up in the next few years.
I really like what you talked about, the fact that everybody's treatment is personalized. Thank you for that, because I think it's really important for people to realize that the fact that your next door neighbor had radiotherapy
Yeah.
doesn't mean that you have to have radiotherapy. Because I think there's always like a herd mentality to be a lot of diseases, and people say, oh, like some guy in my family did this, therefore I think that's the best thing for me. So I think that's why it's also really important we're doing this, so that you hear from people that have done thousands of cases, right? Who have the wealth of experience, who know what the research is saying, what's new about what's going on. So that if you're really seeking help, then you go to the right people. I think like we're really lucky to have this three amazing consultants in this room today who are experts, and not just experts, they've lived it, and they treat they treat people in a country where the volume is really high. And I think that also brings it back to you, Abdullah. Someone says I was diagnosed with prostate cancer 9 years ago. I was treated with seed implants. Cancer was cured, but now I have a lot of complications, just such as dripping and leaking constantly. Any advice for me? I don't know what to do.
Yeah, I mean, okay, so the seeds implant you are referring to is also called the brachytherapy. And it can be one of the delayed effects is a significant impact on the urinary function. The reality is, as an oncologist, while we potentially cause these problems on the long term, but we actually refer back to urologists for help and opinion in this situation. So we cause problems, and we cause actually quite a lot of problems sometimes. But we will then refer back to urologists for advice and opinion as to what can be done. So I will probably forward this question back to Paul and Amran to see what they will do.
Honestly, I love this conversation because I think I love the fact that people can hear what goes on behind the scene when we're doing treatment plans, right? And where we are with medicine now is not just the one person doing stuff, it's about a whole team of people coming together to do what's best for your patients. So I think that's also really important for the people listening. So when you go to a hospital where it's just one person, is the urologist, the oncologist, the everything, then you should worry, right? Because these are world experts, but they're saying, listen, I don't know what to do with this. I need help. Is I ring a friend, like, who wants to be a millionaire or something? It's really good.
Yeah.
Prostate cancer. So I guess, Paul, over to you. And I guess Imran can contribute to it.
Yeah, so it is something that we do encounter, and so there's several situations why you might get those symptoms, and the most common one is what we call radiation cystitis, or you develop essentially an overactive bladder. So you go into the toilet to pass urine more frequently than you should, and sometimes you will drip or leak urine. So we would, in the first instance, arrange a few tests to assess how strong the flow is, whether you're emptying your bladder properly, and then commence some medication. So we start off with treating with tablets. So there are some tablets that can help relax the muscle of the bladder, and in turn relieve some of that intense urgency to go to the toilet, and hopefully reduce the amount of leaking. There's also tablets that can help relax the prostate itself to improve the strength of the flow, and will help with those symptoms also. If things don't improve, then we will do some more tests to figure out what's going on and whether maybe there's something occluding the outflow of urine, which might need a procedure to help. But there's lots of different options we can use.
Thank you so much. Thank you. Imran, I'm going to ask you the next question. Is an enlarged prostate gland a risk factor for prostate cancer?
No. Simple answer.
Not a risk factor. Yeah, perfect. Good. And I'm going to come back to Abdullah. Abdullah, I know that when we were reading your profile, we talked a bit about image-guided radiotherapy. And someone's question is, can you enlighten us a bit about how that works and whether it is more precise than surgery or every other treatment?
Okay, so Image-guided radiotherapy, from its name, it referred to that you have some sort of guide to the radiotherapy, and the way it works by putting some fiducial marker or seeds, but these are not radioactive seeds. In our center we use gold markers, okay, and because you can see gold easily on X-ray, and it's compatible with MRI, so we use that. And then when you take an X-ray, you can see the gold seeds, and you can basically, in a 3-dimension, identify any potential movement of the prostate. So it is, you can think about it like GPS, a tracking device. So if the prostate moves, and we know the prostate moves with the breathing, with bladder, rectal filling, and so on, okay, so this, even though it's a subtle movement, but it's a crucial movement, and we need to make sure we track it so the radiation treatment become accurate. So that is basically how it is done. And this is one way of image-guided radiotherapy. There are other ways of image-guided radiotherapy using, for example, online, we call it, or on-treatment CT scan. So you do a diagnostic CT on the radiotherapy machine, okay? Unlike the standard CT scan, okay, so this is a diagnostic CT on a radiotherapy machine, or indeed more advanced is you have an MR, what's called an MR linac, where you have an MRI, which is much better quality image to guide the radiotherapy. So this is basically what it means. Currently, the most common way is either the gold seeds or what's called the cone beam CT, which is the CT, whereas the MRI is a slightly more expensive, well, not slightly, significantly more expensive, and is not widely and routinely available. But in terms of, it does make the radiotherapy more effective and better. And certainly if you compare it to non-image guided radiotherapy, this is undoubtedly much better. And in fact, nobody will do non-image guided radiotherapy anymore, okay? And that's what, it not only improves on the efficacy of the treatment, but actually reduce toxicity as well.
Of the radiotherapy. Thank you so much.
Absolutely.
Honestly, I think I can go on and on and on, but it's actually like the consultants have been working all day today, I'm sure. And it's actually past 1 hour already. We've been having this amazing conversation. And I just thought I always like to ask the consultant to, like, because I think a lot of people that have joined might have someone that's going through this, might have a relative or themselves or someone that they've heard about that is going through this. And I always want you guys to leave them with a word of like hope, right? That says, listen, there are treatments available, there are things that we can do, and what should we be doing? I think for me, what I learned is you need to try and find out early, even though we don't have a universal screening tool, right? But what I learned also is that once you find out, you need to try and get the right people to treat you. And I think having lived through this same conversation 14 years ago, I can understand what people are going through. So I just wanted to know whether there was something you'll say to like a patient, right? That you just met randomly on the street and said like, and they asked you, oh, listen, I heard you're a urologist. What do I do? How do I protect my prostate? Something like that.
Yeah, I suppose I would say is if you're at all worried about prostate cancer, just get checked, just get a PSA checked, and if that's up, then we can do a non-invasive investigation with an MRI and take it from there. The old argument that raised PSA means that you definitely have to have a biopsy, that's thankfully changed. And in the 10+ years that I've been working as a consultant, when I first used to see patients, they used to come through the door with a high PSA and they used to have a blind biopsy. But thankfully that is in the kind of history books now. All patients get MRIs and then we can actually identify lesions better, target them better. So I think, and as Abdullah said, there's a lot more treatments available for advanced disease, but as you've kept stressing, the best thing is to catch it early. Whatever the disease is, it's best to pick it up early.
Thanks.
Yeah, I mean, I would agree with Imran, and I think, traditionally there's probably been quite a lot of stigma associated with, prostate cancer, prostate disease, and these invasive tests. But things have improved in terms of diagnostics. But I think in terms of the disease itself and the long-term outcomes, it is positive. With treatment, sometimes you don't need to treat if it's not aggressive cancer. So I've got some figures here from NHS England. So I'll just go through some of those. So more than 95% of men will survive with prostate cancer for 1 or more years. 90% of men will survive their cancer for 5 or more years, and almost 80% will survive their cancer for 10 or more years. So, when you compare that across the board to other types of cancers, if we recognize this early, then the outcomes can be very good. And as you said before, Chichi, you can live for many years comfortably. There might be some side effects, but you will live for a long time if this is recognized early.
Thank you so much. Abdullah, do you have a final word for us?
Yeah, I mean, I think, again, my final word is actually, I would say I'm very positive. I think to say to people, if you are diagnosed with a prostate cancer and you have an early prostate cancer, then actually, don't think about it like any other cancers. So this is not like bowel cancer, lung cancer, or other sort of serious things. So you may be even considered lucky to have early prostate cancer as compared to other potential major health problems. So don't be too depressed about it. And there are a lot of things could be done, and there may not be anything need to be done. And for those who have a high risk or even metastatic prostate cancer, again, I think we are much more positive now. We can control, and a lot of patients are living really long time. And that is why we are remarkably busy, because patients just keep coming back. So I think we are far more positive, and I think patients, relatives should sort of feel that positivity and believe in it. But obviously we cannot guarantee anything to anybody, but that is the nature of life.
Thank you.
Okay, but positive is, I think, the best sort of note to end up with.
Thank you so much. Thank you so much to our incredible panel, their insights, and actually sharing the experience with us. I think for me, we left today knowing that if we catch prostate cancer early, which is what I've been saying the whole time, it is treatable. It's not a death sentence, but silence can be a death sentence, I think. Like just keeping quiet, not saying anything, not seeking the right help.
Yeah.
I think for us, taking this message home to like our brothers, our fathers, our husbands, our friends, and saying that there is hope. There's a lot of advancement, obviously, because I know people have joined us from everywhere across the world, Canada, Nigeria, Ghana, the Middle East, and different places. So what access you have is the access you have. And if the access is not available in your home country, you've got to seek the access. Like people that asked about whether if they're planning to come to the UK, we know we've got connections to this amazing consultant school, are always willing to see you at just the shortest notice to make sure like you're doing well. And I think that I just want to say thank you to everyone, especially people that joined. We had a lot of people register, and hopefully we'll share this with them if they couldn't join. And honestly, Paul, Imran, Abdullah, thank you so much. I think the last question was that please share this video for this discussion. We will try and do that. Thank you so much for being part of actually bringing out time at 7 p.m. after a long day at work is a lot, right? And then I just want to thank the Circle Health Group, especially Emily and Kazai, who have actually put this together and lent us their brilliant consultants talk to us about prostate cancer. So I want to say good afternoon from North America, because I'm in North America at the moment. Good evening from the UK and Nigeria and Ghana and everywhere else people have joined to. And I guess we can't stop talking about healthcare and how to get people the best care they have until we have the next conversation. We hope this saves a life. Thank you, everyone, for coming. Thank you.
Thank you.
Thank you.
I'm so grateful. Thank you so much.
You're welcome. Bye-bye. Bye.
Thanks, Paul. You've been a star. Thank you so much.
That's okay, no problem. Pleasure. Thanks for having us. It's been a pleasure. Thank you very much.
Thank you so
Take
much.
care.
Bye.
Bye.